Good afternoon. Dr. Wardinger is a hard act to follow, but I'll do my best. I couldn't help but think as I was listening to him talk, there's a lot of correlation in a lot of the stuff that we're talking about and some of the hormones that we use and how we use them and so forth and so on. But my goal for this afternoon is to try to, as an OBGYN, I feel like I am a primary care provider. We see a lot of women who come to see us at least for OBGYN in their younger years. Many times they don't have a family doc or an internal medicine doc, so they're seeing us for other things as well.
Mic close.
Sorry?
Mic over a little bit.
This one? Okay. Okay, sorry. Yeah, there's two mics. One is for the recording that they're doing and the other is for the room, so sorry. Is that better?
Yeah.
I'll try to stay in the box. You know, they taught us for years to roam the room and engage the audience, and now at Michigan State everything's recorded, so we got to stay in the box to be recorded. So I'll try to remember to stay in the box. At any rate, there's a lot of carryover. So what I tried to think about was some of the things that we're faced with as primary care providers, trying to use the technology that we have at hand now to help us with guidelines, and to talk about some of the areas of confusion where there's disagreement between different bodies that tell us how we should or should not be doing things in practice. So when Carol asked me to give this talk, I said, well, who do you want me to direct this at, and what age group, and what defines geriatrics? And she said, well, it depends if you want a discount at the department store, or AARP, or there's in the geriatric population, the aging population, there is people that are healthy and people that are frail. And I think, you know, David addressed a lot of that stuff in saying, let's use common sense and not treat people for something that is of no benefit because they're not going to be here 5 or 10 years from now. So I'll try to work around those guidelines and thoughts as we move forward as well. But I think that we're all aware that the baby boomers are here in the geriatric age group. If you want to define that as age 65, I think that was about 2011 by the definition of the baby boomer population that they all started getting their Medicare cards. And so the population of older men and older women is going to exponentially increase in the next 10 to 20 years. And part of that also is because people live longer now than they did 50 or 100 years ago. So these are my disclosures. I do nothing relevant to today's topic per se, except that I am over age 65 and I do fit some of the categories that you see up here. And I have been carded for purchasing alcohol over age 60. But I think that's only so that the person who's waiting on me can get a better tip. And I'm not sure where the next slide is. Okay. So about 9 years ago, ACOG, our college that gives us guidelines and direction in keeping current, decided that we should expand our training in gynecologic care. Again, that's addressing the aging population. So there is more focus on that, and for me, as a program director in training residents, I need to be more cognizant of that as well. So once again, just to kind of summarize some of those things, age alone should not be our sole determinant for how we're treating our patients. We have to take into account, for one thing, we want to keep them active. We don't want to just put people away at age 65 or 70 or whatever age we determine. Keep them active, keep them engaged, and then treat them dependent on quality of life. What do they want? What screening tests do they want or don't want? What treatments do they want or don't want? And I think our job is to try to guide them and again, use common sense should prevail, as Dr. Wardinger said, in how we handle these patients. So for today, the primary topics I'm going to hit upon, and the goals and objectives are listed here. And primarily I'm going to talk about a little bit about breast and cervical cancer screening. That's a far cry from urology stuff, but it's stuff that we're confronted with and there's controversy over. So I want to just summarize some of the guidelines for the aging population. I want to talk about treatment, hormonal therapy or non-hormonal therapy for the menopausal patient, because again, we're talking about aging. The ovaries start to decline in function around age 50, 52. The average age of menopause in this country is age 52. And we certainly have a lot of controversy, especially after 2001, when WHI came out with their data that kind of shook up the hormone world and menopausal world and how we manage and treat our patients. So we'll talk a little bit about that. And then also focusing on genitourinary changes of atrophic changes in the genital region and effect on sexual function, which is a huge factor for many women postmenopausally as well. And then finally, talk a little bit about bone screening and prevention of fractures of the vertebrae in the hip and how to address that. So I'm going to kind of go through these things, talking about the guidelines, where there's crossover in the guidelines, talk about comorbidities. I am going to ask you to, in spite of what Dr. Monson said, you don't turn on your volume, but you may get out your phones because I'm going to direct you to some apps as we go through the course of today's presentation. And of course, these presentations are available for you electronically as well. So all the things I say today and the references I make to those apps and other electronic resources are things you'll have an opportunity to look at later as well. And or you can always go to Google and find these things as well. So this is just my little statement to say it's okay to get out your electronic device if you want, if you so choose to do so. Just turn off the volume. So I want to talk a little bit about cancer screening first, and again, we'll focus on breast a little bit, and then a little bit on cervix. Again, I'm trying to move through some of these topics to kind of get through the overview through this session, and thinking back to Dr. Wardinger's presentation as well. The last hour we have today, if you choose to stay around, is going to be discussion and Q&A, and really try to address things that, if we didn't address them here, that we can address those questions at that time. So whenever we think about screening tests, we think about, we want it to have high level of sensitivity and specificity. And some of the problems we have, as with PSA, is it may have sensitivity, but their specificity may be an issue, and so forth and so on. It's why we don't use CA-125 for screening for ovarian cancer. And then we have to decide what are the harms and benefits of screening. We kind of have heard in the last few years about our previous thoughts about being aggressive in cervical cancer screening, starting early, treating people early, really didn't make any difference in outcomes. And if we had left our hands off of younger women for cervical problems, that a lot of these problems would have gone away on their own. So we've learned that over time, and we've changed our approach. Likewise, for breast cancer screening, we have to decide if we do a mammogram and we find something, we do a biopsy and other procedures to them, what's the effect on them psychologically? Like Dr. Wardinger said, once you've heard that word cancer, it plants the back of your brain. And we have to take into account potential harms that we might have in doing procedures to patients that may not make any difference in the long run. So talking about breast cancer screening, we know that breast cancer screening is common. 1 in 8 women in this country will develop or be diagnosed with breast cancer during the course of their lifetime. So we also know that mammography has been a significant help in terms of reducing morbidity and mortality. Our treatments for breast cancer have also increased, or improved, I mean, so we have better outcomes that way. But there's lots of controversy now about when do we start, at what age, how often should we do it, when should we quit? So far, I don't think insurance companies are not paying for this, but potentially I can see us being dinged in our report cards electronically if we're doing things not at all or doing them too frequently. And then, but whose guidelines should we follow? We're going to see momentarily there's a lot of variance in the guidelines that are out there currently. So this looks like a meeting of the United States Preventative Task Service Force in this cartoon with the doctor in the middle of the room and saying, anybody want my opinion? And that's kind of what we feel like sometimes. I think what Dr. Wardinger was alluding to as well is that we have governmental bodies and others that are telling us what we can or can't do, and maybe for the right or wrong reasons, but sometimes we feel maybe not for the best reasons for our individual patients. So once again, we have to take all these factors into account. Breast cancer is very common, as we know. We've talked about that. Some of the numbers are here. I don't need to reiterate them for you here. It's only to remind you that many, many women die in this country every year from breast cancer. So when we have those conversations about starting at age 40 or starting at age 50 and doing every year or every other year, whether we should be doing breast exams in our offices, whether we should be advocating against self-breast exams, et cetera, we have to remember that if you're that individual who's 40 years old and had breast cancer, and we may have been able to pick that up with earlier screening, we have to take that into account. And I'm not sure sometimes, especially from the U.S. Preventative Testing Service Force, that they account so much for the individuals as they do for population statistics. Then they talk about individualizing your discussion and your therapy choices with the patient. So I think it's good to have that information in mind, but I would just say whether we're talking about breast or cervix or other screening tools that we use, these are guidelines, and then you have to talk to your patient, find out what their preferences are, and try to help them make the best decision. So the bodies I'm going to look at today briefly are, in their guidelines, are ACOG, the U.S. Preventative Task Service Force, the American Cancer Society, and the National Comprehensive Cancer Network. The National Comprehensive Cancer Network we see that frequently, but it's a group of different cancer centers around the country that come out with their own recommendations and statements. And for the purposes of breast screening, you're going to see that ACOG and NCCN are pretty much right in line with each other as far as their recommendations and guidelines are concerned. So ACOG says, this is relative to the clinical breast exam, that is the provider doing the breast exam. We should be doing it every 1 to 3 years in women ages 20 to 39, and then annually in women after age 40. U.S. Preventative Task Service Force says we have insufficient evidence to state that that's a benefit or a harm, and they don't advocate it routinely, but they say you can have the discussion with your patient, and they talk about breast awareness. This is kind of a quick summation of what the U.S. Preventative Task Service Force said in 2015, and they did retract a little bit, which I'll talk momentarily with the breast exams. So they say a woman with a parent, sibling, or child with breast cancer may benefit more than average risk woman from beginning screening between ages 40 and 49. So even though they advocate not starting until 50 for the average risk or low risk person, they do advocate or say you can start earlier if you have a patient who is at higher risk, family history, et cetera. Also, won't be a big focus of our discussion today, but I think it does come up, so I put it in here. They basically say the current evidence is insufficient to assess the benefits and harms of tomosynthesis, 3D mammography as being better or superior as a screening modality than our traditional mammography. I think we're seeing more of that coming out, and it will happen, and that's fine, but I don't think for our patients' sake that they necessarily are getting a better screening tool right now. At least we don't have the evidence to show that compared to the traditional mammogram. And this is where they made a little bit of a backtrack on their statement from 2012. They're still recommending against clinicians teaching patients self-breast exams, but they now, and D recommendation means that the risks outweigh the benefits in their opinion. But now are recommending breast awareness and self-reporting of any changes to patients' healthcare providers. So that breast awareness is a term that kind of came about in the last, number of years. It wasn't a word that I don't think we saw before. And so I tried to look a little bit about it to say, well, what are people defining as breast awareness? And basically, it's a woman's awareness of the normal appearance and feel of her breasts. And they do note that 50% of all breast cancers are detected by women themselves who are over age 50, and 70% women less than age 50. So it's, in spite of all our efforts to do and teach do exams in the office, the patients many times come in and say, I found this irregularity in my breast, can you check it? And then it turns out it's breast cancer and so forth. So most bodies, ACOG and others, say breast self-awareness should be encouraged and can include a breast exam. So it kind of puts a breast self-exam. kind of puts the ball back in your court to have that discussion with the patient again. The same term is endorsed by the American Cancer Society, the National Cancer Network. The American Cancer Society in 2015, just this past October, came out with their guidelines, and they do make a point in their this was in JAMA and published elsewhere as well, that this is for the average risk woman. And they also made a statement in there, although I haven't seen it come out yet, they're going to be coming out with a similar white paper guidelines for women who are at higher risk and what those recommendations should be. So they say women ages 40 to 44 can begin screening mammography, annual mammography, and have a discussion with your provider and decide based on personal choices and providers' recommendations, yes or no. They say they should have annual mammography for the next decade, age 45 to 55. And then over 55, you can transition to every other year, or you can continue with annual screening. So I think that with these kind of guidelines, it's going to be hard pressed for insurance companies to drive you in a certain direction when you have national bodies that are of experts getting together and trying to make these kind of statements that I don't think that'll come to haunt us right now, but it's still confusing for people. It's confusing for patients to hear this stuff on the news and say, well, what should I do? And also, we should stop doing mammography similar to what Dr. Wardinger talked about with prostate if your longevity, life expectancy is less than 10 years. And then women at any age should not rely on breast examination alone for breast cancer screening. The National Comprehensive Care Network this past winter, shortly after American Cancer Society guidelines came out with their repeat statement that they believe that annual screening should start at age 40, and that should include an exam every year along with annual mammography. And in spite of the concerns that we've heard about the harm of screening, NCCN said, and I'm quoting, "We have a big problem with the harms analysis that have been done by both the U.S. Preventive Task Service Force and the American Cancer Society." That is, they talk about the harms of screening, but they don't talk about the harms of not screening. So in a sense, they're comparing the harms of screening with no harms, but that's clearly not the case. So again, these things get personal. If you know somebody in your family or a friend or somebody that's had cancer in their 40s and got picked up earlier, you would probably lean towards advocating towards earlier screening. I think, again, when you look at, particularly the U.S. Preventive Task Service Force, it's population-based, and they're saying, here's the statistics, here's the chances of overdiagnosis or false positives with screening at this age, and then versus the yield. So this is kind of a summation of, and I've got a few slides here. I'm only going to gloss over them because you, again, have these slides in your slide deck if you choose to look at them. But the U.S. Preventive Task Service Force says age 40 to 49, it's a personal decision and discussion with the patient. And they don't have a strong statement either way on that. 50 to 74 is when they recommend the screening occur with mammography at every 2 years. And then over 75, more research is needed. They say insufficient evidence to support doing it. So again, I think it's up to your discretion. American Cancer Society, as I've already alluded to, says 40 to 44 is your choice every year for the first 10 years because the breasts are denser until after menopause. So every year from 45 to 55, and then every 2 years after age 55 up until age 75 or 10 years of longevity or more expected. If it's less than 10 years longevity because of other illnesses, then stop doing it. And then NCCN and ACOG still support annually, at least up until age 75, and or that 10-year rule again applies. And this is just kind of there's a few slides that I'm not going to go over right now for the interest of time, but just, again, a way of comparing and contrasting the different societies and their recommendations. But I wanted to just bring this slide to your attention because it kind of talks about where I think some of this is coming from, particularly from the U.S. Preventive Task Service Force. And they show that in that first column, excuse me, that the false positive result in different age groups. So There's a higher level of false positives in the 40 to 49 year age group, then that goes down progressively with age. As we know, just like with prostate, the longer you live, the more chance you're going to get breast cancer. And so the incidence of false positivity goes down over time. And those that need a biopsy is listed in the second column. Pretty similar across the board, really. And then actually making the diagnosis of cancer, this is per 1,000 women, by the way, the rates. But it gives you, you can see the relative comparisons. And the number of women needed to be screened to prevent one death. You need to screen 1,900 women in the 40 to 49 year age group, goes down to 1,300 in the next group of age 50 to 59, and then see a big drop to 377 in the 60 to 69 group, and not enough data available to discuss beyond age 60. But this is where U.S. Preventive Task Service Force comes up with their recommendations about their guidelines. These next two slides are just more of the same data that you can just, they're in your slide deck. And we talked a little bit about 3D already, so I'm going to skip over that, except to say that pretty much all bodies are in agreement. We don't have enough data right now to say that this is a superior or better means of screening. And I'm not a radiologist, I'm not a surgeon, so I'm primary care, OBGYN. I screen for breast cancer. I'm not an expert in those areas, but that's what the information is telling us. So how can we enhance our breast cancer risk screening? Well, I think that a lot of what we do these days, we focus on electronics. We have quick access to resources electronically. This is an app that, really, this is not new. This is a breast cancer screening that has been around for a long time. It's a series of 9 questions, but there's an app for it now. And you can very quickly go through the series of 9 questions relative to risk, taking into account her age, time of her menstrual period, time she had her first child, all the things we know are potentially risk factors for breast cancer. They come up with a 5-year risk and a lifetime risk. So that's a way that you can help the patient, or the patient can help herself by doing this app and very quickly coming up with those statistics. So I think that when I'm having a conversation with a patient in my office, if I can show them something besides what I think, and here's what the evidence shows, and here's a screening tool you can use, then they can either take it home and do it themselves, or you can do it very quickly in a matter of 1 or 2 minutes when you're sitting there next to them in the office and tell them, here's your 5-year risk, here's your lifetime risk versus the average woman. It helps you decide what direction you want to go down with, and it helps the patient decide what direction she wants to go as far as screening. So that's really all I'm going to say about breast cancer screening, except that I know it's confusing for our patients. It's confusing as a provider sometimes. Certainly, this slide in the lower corner here, this came out after the American Cancer Society came out with their recommendations in October, because they had a friend or a loved one who they lost to cancer at a younger age, and that becomes very personal, and they felt that, again, this was population-based and based on saving money, and did not apply to them directly. So the next uncontroversial topic, or controversial topic, depending how you want to look at it, is cervical cancer screening. And I'm not going to spend as much time on this, except just to go over it quickly, because I think we've heard a lot about this, and you probably heard a lot about this in the since 2012, when these guidelines really started to change a lot. And they've gotten, I used to know this stuff cold, even after the American Society of Cervical Cytology and Pathology came out with their guidelines in 2012, I could pretty much recite everything cold. Now the algorithms have gotten so complicated that if you're trying to follow their guidelines, you really do need an app, and I'm going to give you an app for that too if you don't already use it, to help. And it's very nice because it can very quickly give you the recommendation as to what at least the guidelines are that you should do next. Again, we can come back and focus on some of this. There are specific questions during that last hour of discussion time. Again, wanting to not say things you already know, but be happy to discuss things if there's confusion about it. So we know that cervical cancer, prior to Papa Nicolau developing the Pap smear, right around the time of World War II is when it really started to be used. And it significantly allowed us to make a diagnosis of cervical cancer earlier and treat people accordingly. And of course, our understanding about this has changed dramatically, even just in my time in training and practice. When I was a resident in training, and it was great for surgical training, every single patient that had a cervical carcinoma in situ got a hysterectomy if they were done with childbearing. And of course, now we know we don't need to do that. So things have changed. Also, the frequency or the incidence of adenocarcinoma has gone up compared to what it was when I was in training. Now it's probably about 80% squamous and 20% adeno. The reason that's important to know if you're a primary care physician screening and or you're doing colposcopy is that adeno tends to be more up in the canal. It tends to be skip areas more often. And so when you're diagnosing or treating that, if you get a PAPS, for instance, atypical glandular cells, for instance, you need to know where to sample and where to look. And so beyond that, I'm not going to say a lot about cervical cancer. We know that cervical cancer screening plays a role. For us, historically, it's been every year you do a pap smear. Now that's changed, and we know we don't need to do that. We also have a better understanding about HPV, co-testing, or reflex testing, and so forth. But again, none of that pertains to the non-geriatric population, so I'm just kind of glossing over it right now. So the question to address today is, beyond age 50, how often should we be doing pap smears? And then when should we stop? And what about if you had a hysterectomy? And so forth and so on. So this is a quick summary of the cervical cancer guidelines overall. If you look about halfway down, women 30 to 65, the recommendation is to do cytology. If you're just doing cytology alone, it's every 3 years until age 65. If you're doing cytology and HPV testing combined, which is called co-testing, that from age 30 to 65, that can be done every 5 years. So you enhance you can decrease the screening interval if you're doing both together. And then over 65, it's generally recommended that you don't need to do continued pap smears unless they've had a previous significant lesion, CIN2 or 3, a high-grade lesion, or cervical carcinoma in situ. Then there's different guidelines for that, and that's all listed here. And then if you've had a hysterectomy, and when we say hysterectomy, we have to account the cervix because there's been a trend for a while of doing supracervical hysterectomies like laparoscopically. If they still have a cervix, then they still need pap smears up to age 65, same guidelines. If the cervix is gone and the uterus was taken for benign reasons, they had no previous history of dysplasia, then you can stop doing pap smears. You don't need to do pap smears anymore after they've had a hysterectomy. So those are the guidelines. If they've been vaccinated, we're still following the same guidelines currently because we just don't know in the long haul. And if we've covered everything, we're covering most of the HPV types that cause cervical cancer, but we still follow the same guidelines. So if you have a patient, for instance, who's 45 and she decides she's going to have the co-testing every 5 years, at age 45, she was negative. Then at age 50, she comes back, and now she has an ASCUS pap smear, atypical squamous cells of undetermined significance, and she's HPV positive, or HPV negative, what's the recommendation? So you have a pap smear that's nonspecific, atypical squamous cells. You have a negative HPV. What do you suggest now? Well, you might, if you do this often enough, it might be cold in your head that you know what to do, or you may not do PAPs that often or deal with this that often, and it does change by age range as well. So that's where having a quick guideline or app comes in handy, I think. And this is the ASCCP app. Now, the breast one I showed you is free. I'm pretty sure it's free. Might be $1 or $2.99. The ASCCP one is $9.99, which for me is still a godsend because I use it every day. And it's very quick and easy. And this is what it looks like on your phone. So it asks you what's the age of the patient, and it plugs in the categories we talked about. HPV status, positive or negative, or question mark if you didn't do one. Pregnant, yes or no. And then what's your PAP result? ASCUS, AGUS, LSIL, HSIL. Plug all that in, and then it'll give you a recommendation. So for this lady I plugged in that information, and she's HPV negative, remember, the recommendation was to repeat co-testing in 3 years. If it was HPV positive, then you'd go to colposcopy. So that, again, if you don't know these things or you're not sure, it's nice to have, I think, this quick app. So Anything else, when you have somebody who has LSIL, HSIL, ASCH, that's atypical squamous cells favor high grade, or AGUS, atypical glandular cells, those all warrant going to colposcopy. So you don't even need to worry about what the HPV is, you should just go to colposcopy. So now she's 65 and she wants to discuss stopping pap smear. She's not had an abnormal pap since that one at age 45 or 50. How would you counsel her? And we've already kind of alluded to this, but the recommendation is cytology and HPV co-testing every 5 years until age 65, or every 3 years if you're not doing HPV testing, and then when to stop if there's no history of neoplasia or adenocarcinoma, as I've mentioned, and they've had 3 negative consecutive pap smears in the last 10 years, or 2 consecutive negative co-tests, because remember the co-testing is only every 5 years, in the last 10 years, then they can stop testing at that point in time. She may discontinue pap tests at this time based on criteria. This does not guarantee she won't develop cervical cancer, but the chances of that will be really remote. Now, if you have a situation where you think, oh man, she's high risk, I should still do this, or the patient says, I don't care. I've had many patients say to me, I don't care, I just want a pap smear. I'm here for a pap smear, you're gonna do a pap smear. I'm like, okay, that's fine, but these are the guidelines. We do know more now than we knew then, but it's fine to go ahead and do that, I believe, after discussion with the patient. But the up-to-date, and this slide comes from up-to-date, says continue to offer screening for cervical cancer to women with good life expectancy, that's the 10-year rule, who have risk factors for cervical cancer, and they list a history of an abnormal pap, which we've talked about, current smoker or history of smoking, that's not covered in other guidelines, unknown prior pap test history. If I have a patient, and we have patients in it's a very mobile population, obviously, that we see, and people lived in Alabama last year, and live in Michigan this year, and Florida next year. If they come to my office and they don't know, or I'm not sure, I'm going to go ahead and get one, at least get a baseline, and then go from there. If they have previous HPV-related disease, those are all things that, at least up to date, and up to date, remember, is more opinion. It's written by quote-unquote experts, but it's more opinion-based. But they recommend continuing some kind of surveillance beyond the normal guidelines. And then finally, the big question that always comes up is, I was in a monogamous relationship for my whole life. My husband passed away. I moved to Arizona. We played bingo from 6 o'clock to 8 o'clock. Then after 8 o'clock, there's extracurricular activities that we do. And so they have new partners or different partners. And the question is, are they at risk or should they still be screened? ASCCP says no, you don't need to worry about that. They're at low risk for a lot of different reasons. That has to do with the physiology of the transformation zone. That's where the dysplasia or cervical changes take place. It's not as vulnerable at that age as it is in women's younger years, et cetera. So ASCCP says no. The group that wrote this article and Up to Date say yes. You can have that discussion or leave it to your discretion, and then go from there. But at least the pap smear guidelines were all over the map, kind of like breast cancer was until 2012. And then since that time, ACOG, the American Cancer Society, ASCCP all kind of came together, said, here's the guidelines. You may not like them or agree with them, but this is what they are, and then at least you're not going to 3 different opinions. So the rationale for stopping at age 65, I alluded to some of those points here. I'm not going to belabor them except to tell you that it's in the slide deck if you want to look at it. How are we doing on time, Carol? Good. Okay. And this is just some of, again, the rationale for stopping at age 65. Again, I already mentioned about hysterectomy. I mentioned about vaccinations. And then general guidelines would always say, if you have low grade, high grade, ASCH, AGUS, you always do a colposcopy. With ASCUS, it depends on HPV positivity or negativity, and we kind of covered that already. And this is just a summary slide of what I've already talked to you about with screening guidelines and management guidelines. Yes, ma'am.
You talked about no pap smears after hysterectomy, but what about somebody who's had a hysterectomy for a malignant reason?
Oh, then you would. Absolutely, yeah, yes, yep. And you follow the routine screening guidelines.
Right.
Yep.
And I think that point you made
And they say for at least 20 years is the general rule.
20 years.
Yeah.
That
Now,
point you made was very good because many times the cervix is left behind and people just assume
right.
that the cervix is gone.
Yeah, and again, because we live in a mobile population, unless you put the speculum in, and I won't be as descriptive as Dr. Wardinger was with the penis, but we do go in the vagina, and we look up there, and if they have a cervix and they need a pap smear, many times patients don't know. They say, I had a hysterectomy. I had a total hysterectomy. Well, what does that mean? They think that means it's uterus, tubes, and ovaries, but it's variable. So we have to, when in doubt, we look. Okay. The only other thing I want to mention briefly, and again, this is not so much geriatric population, although it could be, is what is the role for just doing HPV testing alone? It's been suggested, and in fact, it's been approved now. The FDA has actually approved that you can use HPV testing alone, and there's protocols for that, which I won't go into detail here. I put the basic essence of it here, but it's all about HPV testing. If they're high risk positive, you can do genotyping for 16 and 18 because those are the two types that are the highest risk. 70% of squamous cell cancers of the cervix come from 16 and 18. And so there's protocols out there for that, but I just put it in there in case it comes up as a discussion point or you wanted to know more about it. And then this is you can go to the ASCCP website and get all their algorithms for free. You don't have to be a member. You can go to their website, and if you choose to, but actually when you go onto the mobile app, they'll actually direct you to their algorithms and tell you what direction to go. So you don't have to use the website, but it's there if you want it. Okay, now we're going to switch to geriatric issues of menopause. Many people in this room, I can tell, were in practice in 2001, except for Otto. You didn't start practice in 2002, did you? So, seriously, though, 2001, when WHI came out, created a huge monster for people in terms of how to deal with menopause and treating menopause. And I always like to remind people, talking about WHI as one example, when I'm teaching residents or medical students, is, we talk about evidence-based medicine all the time, but let's use the evidence for what it is. If a study was done on women average age 63 and addressed the population that age and older, then let's not apply that to the woman that's 45 years old or 40 years old. So the evidence has to fit what was actually studied. And unfortunately, because of pressures from society, pressures from attorneys, pressures from websites that have all the class action suits for everything you can think of on there that's controversial, then people say, I'm just not going to do it. And so, everybody's hormones went down the toilet in 2001 until people started having a lot of issues, of quality of life issues with menopause, and then gradually hormones have worked their way back in. And I think the good thing about that era of time is that we do individualize much more now than we did before. So it's what do you want, what's important to you. If I have a woman who's had breast cancer and she is post breast cancer and she wants treatment that may be hormonal, I'm going to have dialogue or make her have dialogue with her oncologist about it, but I won't just close the door and say we absolutely can't do it. It's the patient's choice, in my opinion. It's patient autonomy at the end of the day, and we're here to give guidance and suggestions and say this is what evidence says is best or not best. But at the end of the day, and then it's all about documentation beyond that, I believe. It's just, you have that discussion, but then document why you did what you did or what your discussion was. So I'm going to talk a little bit about vasomotor symptoms of menopause and then talk about what's now the new term, genitourinary syndrome of menopause, or GSM. You'll be seeing that more in the literature now. It really is atrophic vaginitis and all of the atrophic changes that affect the labia, the clitoris, the urethra, the vaginal introitus. It's all very estrogen dependent, and there's many issues that come up for women postmenopausally beyond hot flashes that affect their daily activity, and particularly their sexual activity, which can lead to, marital discord and so forth and so on. And then we'll talk a little bit about bone at the end as well too, because that's really a manifestation of menopause as well. So hormone replacement therapy, as we used to call it, the FDA after 2001 said you can't call it that anymore, you shouldn't call it that, you should call it hormone therapy because replacement implies that you need to have this replaced. And then really it's optional whether you have it replaced, it's not mandatory. And so the terminology HT, hormone therapy, means estrogen and progestins, and then ET, which is a movie that we saw back in the early 80s, but also implies estrogen therapy only. And of course, that's typically for the woman that has had her uterus removed. Because unlike I lived through the whole era of giving estrogen back in the 70s and finding out, oops, it causes endometrial cancer, so it went away. Then it came back with progestin because progestin was used to protect the endometrium. And then we found out after WHI that progestin may actually be the harmful piece, at least the medroxyprogesterone may have adverse effects or risks of breast cancer over a number of years, as opposed to the estrogen alone, which actually was shown to not increase breast cancer at all, at least in the WHI. So I've listed here the common symptoms if you have trouble remembering those, you can go back to our friends, the Seven Dwarfs, and talk about some of the symptoms that women experience. And even though we laugh and joke about this, this is a serious quality of life issue and affects people's daily functioning and activities in the home, at work, interpersonal relationships, etc. So it's something that we can joke about it, but it is really a serious life issue. So here's a sample case. And when I started putting this together, I originally was going to do some clicker style questions and stuff and try to gauge people that way. And I thought, it does slow the delivery of presentation down somewhat. And I decided to take some of that out. So this is a 53-year-old who comes in with difficulty with sleep. Her last menstrual period was 18 to 24 months ago. Remember, the definition of amenorrhea is 12 months. So a woman's truly not menopausal by definition until she's 12 months out from her last menstrual period or more. But we also now understand that you can have menopausal symptoms, vasomotor symptoms particularly, because your ovaries are waxing and waning and not be truly menopausal yet because you're still having periods. But this woman's last period was about 2 years ago. During your history, she further notes she has sweating constantly at night. This is the primary cause for her insomnia because that's the reason she came in originally. We know that menopause and estrogen deprivation causes a change in our deep sleep. So even if you are sleeping, the quality of sleep is less. So the woman is more irritable, and that may be what leads to some of the depression and other feelings that way as well. And then you suspect she's suffering from vasomotor symptoms, so you discuss, what do you want to do? How can I help you with this? You probably get into the discussion of hormones or neurohormones, and then they'll tell you, I read on the internet or I went to my hairdresser, and she said, why would you want to do hormones? They cause cancer. So then you have to get into that whole discussion as well. So just a quick overview, because I know many of you know this, and again, we can go into this in discussion, but these are some of the things that we would talk about. If you want hormone therapy and you still have a uterus, you should get progestin along with the estrogen. For estrogen, we have many different products that are out there. We'll talk about bioidentical briefly as well here. Orally, we can deliver it orally, we can deliver it vaginally, we can deliver it transdermally. We have estradiol, we have conjugated estrogens, both from horse urine, plants, and other sources. We have combined products that have estrogen and progestin together. We have a newer product that has estrogen and a SERM, selective estrogen receptor modulator, basidoxifene, which is it's not a progestin, it's a modified estrogen, but it actually is protective to the endometrium, so you don't need a progestin. That's a newer product that's out there. Insurance may or may not cover it, but it might take some of the issues away from some of the concerns we have with progestins. If she has a uterus, you should offer her and should recommend protection because we know that the risk of endometrial neoplasia goes up if you just give estrogen alone, unopposed estrogen. The progestin can be given orally or could be given. A way that we're more favorably doing it now and taking away some of the systemic problems is with the levonorgestrel IUD, that's Mirena IUD. There are transdermal products out there, particularly bioidentical ones for progesterone. Every article that I've read on that says transdermal progesterone does not protect the endometrium, so you can't advocate for that. The other problem, which we'll come back and talk about with the bioidentical compounded hormones, bioidentical is the word on the street, but really a lot of the pharmacologically approved hormones are bioidentical. But the compounded hormones are not FDA approved. They're not as well regulated. They're typically state regulated. There's differences in quality and what you get delivered from time to time. So there's all those particular issues involved. And there's a thought among the general public that, well, this must be better. It's matched just for me. They're measuring my salivary estrogen level. There's no data to support any of that. So just a word on that. If the woman can't take estrogen, and we should avoid estrogen, we all know this, but just for the sake of completion, if they have a history of DVT or they're at high risk of DVT, thromboembolic disease, if they have a thrombophilia, and the most common one is factor V Leiden, if they have a history of or active breast cancer, those are generally deemed to be contraindications, particularly to systemic hormone therapy. So in further, then if you get into the non-hormonal therapies that are out there, SNRIs, SSRIs, paroxetine particularly is the only non-hormonal treatment that's been FDA approved. The recommended dosage for that is 7.5 milligrams of paroxetine. So it's lower than the therapeutic dose for depression. Clonidine and gabapentin have also been used, and they are better than placebo, but every study you look at will still tell you that given the choice, estrogen is still the gold standard for treating vasomotor symptoms of menopause. Any placebo will give you about a 30% response rate, at least for a short duration of time, and then that tends to go away over time. And then there's lifestyle issues, layered clothing, breathing techniques, lowered room temperatures, doing yoga and other meditation type things. Those are things for the motivated patient. If they want to do those certainly could be helpful, and you can have that discussion as well. The biggest problem I see, in the interest of what Werdiger talked about earlier, is time you have with the patient. How much time do you have to spend? Moving on to the next patient that's waiting, et cetera. So again, I think using electronic resources and references for them to go look at, especially if they're internet savvy and want to look at that stuff, you can give them good direction to go, because if they just go on the internet, it's all over the map, as you know. The information they get may be accurate or not accurate. So if you get further on in the discussion and she says, oh, by the way, I'm having pain with vaginal intercourse, it's become prohibitive, it's affecting my relationship with my partner, and I'm feeling dry all the time, and I'm having a cessation of burning, then you can talk about local therapy. So when we talk about vaginal atrophy, the treatments are, we can use lubricants, we can use moisturizing, long-acting moisturizing agents that are available out there to help with more continuous moisture all the time, where the lubricants, when we're talking about water-based or silicone-based lubricants for intercourse, if that's all they need, then that can be helpful. You may be able to stop right there. Or you may use topical estrogen for a short period of time and then go over to just lubricants, because what we found with menopause is that if the vagina is used, and if you are sexually active, then it becomes less of an issue with all of the problems that we see with the postmenopausal atrophic vagina otherwise. And we're talking about loss of normal moisture, loss of blood supply to that tissue, loss of elasticity, shortening of the vagina, and those can all be rectified with estrogen, but also they can be more normalcy maintained by regular maintenance use of the vagina, if that's a good term, maintenance, I don't know. Normal for us, guys, I don't know about you guys. And so what are the estrogens that we can use? So there's estrase vaginal cream and Premarin vaginal cream. Those are the brand names, but those are the only two that are out there. No company has gone to making generic estrogen creams because it's expensive, the generic companies, and they don't want to spend the money or the resources to produce it. That's my understanding And so they're not there. And so then we have the cost issue and whether insurance covers it or not. There's also the vaginal tablets, Vagifem. There's even an ultra-low dose of that now. Typically with that, it's a low-dose topical estrogen that you use intravaginally daily for 2 weeks and then twice a week after that. Or the S-string, which is the estrogen ring, and I've used that successfully in my practice for a number of years. The patient can take it in and put it in and take it out themselves. Or if they don't feel comfortable, or if their arthritis prohibits them, they still want to do it. I've had patients come in every 3 months, because that's how long it's good for, is 3 months. And then you can just change it for them there at the office and reassure them and send them on their way. And it's an ultra-low dose estrogen as well. So the big thing with any of these topical low-dose estrogens is you do not need progestin to protect the endometrium. The studies that have been done, and the only ones that are really published out there, are for 12 months. But you should still have an awareness about estrogen's effect on the endometrium, that blood level-wise and follow-up-wise, there's no reason to believe that women are going to develop endometrial neoplasia or carcinoma from topical low-dose estrogen. And you take away the other systemic concerns as well. There's a newer SERM out there, ospemifene, that's approved to treat dyspareunia. It also it treats hot flushes as well, so it has those benefits. Has no estrogenic activity at all on the endometrium or the breast, so it takes away that concern. It's relatively new, so there's not a lot of long-term studies or head-to-head studies with other agents, but it's out there and can be helpful for both the reasons that we talked about. This just reviews the symptoms of menopause. You're well aware of that. I think the biggest point to make here is that, people make the assumption most women, the changes in the vasomotor symptoms go away after 5, 6, 7 years for the most part. But there's always that subset of the population and that we have continued persisting symptoms. And in my practice, I always had women in their 65 and beyond age group that would shoot me if I took away their hormone therapy. So we'd have that dialogue every year and say, well, you're doing fine, everything seems to be fine, your lowest for breast cancer, your mammogram's good, I think it's okay, but just be aware that there's some data to show that with increasing time, your risk of breast cancer might go up. Your risk of DVT is always there. But usually, I think that the risk of DVT and associated problems is more, you're either going to have it when you go on it or you're not, and then your risk might go up somewhat with age, but not dramatically if you've already been successfully on it. So there's a big difference between starting somebody on hormone therapy at age 63 versus starting them at age 50 or 51 and then continuing them on for as long as they need it or feel they need it, and have the dialogue with them every year when they come in for their well-woman exam, whatever that means anymore. But at least have the dialogue and say, this is something we can continue or not, how do you feel about it, and so forth and so on. So again, it's having that conversation with our patients, individualizing therapy, and just helping them understand what's safe or not safe. And then again, if you're going just after the atrophy, and a significant percentage, and the atrophy tends to come after the hot flushes for the most part, and tends to get progressively worse if left alone, as opposed to where the hot flushes might go away over time. So 10 to 40% of women report vaginal atrophy as being symptomatic. That's probably underreported, because if you don't have that dialogue, then you're not going to know, and so forth. How are we doing? 5 minutes? Okay. So this is some of the things we might come back and talk about during the discussion time if you so choose, or I'll meet you at the bar 2 hours from now and we can have a discussion there. Dr. Monson, we have a grant. Whoops. So we could talk about bioidentical hormone therapy. I've mentioned some of the issues there. We can come back around to that and talk about some of these things. These other slides, which again are just in there for your perusal if you choose, it's really just a summation of what I've just said. In 2013, a bunch of people, experts from around the world, decided to get together and address hormone therapy and menopausal therapy, not just hormone therapy, but menopausal therapy, and come up with a consensus of what are the things that we agree upon. what should you do, what shouldn't you do, and leave the things that are in question alone. And it was called the Global Consensus Statement of Menopausal Therapy, and it was published in multiple languages around the world with whoever participated in this. And it came from the International Menopause Society. And these are the statements. Generally speaking, most people would say that hormone therapy started at average age of menopause, which is around age 51 to 52, for 10 years is going to be safe for most women, low risk, may reduce the risk of heart disease. We're not using it to prevent heart disease, but we're saying there's data to support in those first 10 years that it does not increase it, and it may actually be protective. And that goes back to some earlier monkey studies that we could go on for days talking about. But then after age 60, more than 10 years out, then the discussion gets a little bit more complicated as far as what you have and don't have, and that's all addressed, with the patient. That's all addressed here. Don't forget one of the other benefits. We'll talk about this momentarily, or maybe we won't. We'll talk about it in the discussion if there's time. But osteoporosis is a big concern. Women start losing bone mass. We all lose bone mass over our lifetime. It peaks at before age 30, probably in our 20s, and then goes down from there. But after menopause, women lose a significant amount of bone quickly in the first 3 to 5 years. Then it kind of levels off and continues to go down. So we know that women are at greater risk for osteoporosis and related fractures, which leads to quality of life issues and nursing home care and so forth and so on. And one of the indications for hormone therapy is prevention of osteoporosis. So we know estrogen is protective to bone. We know it works, it's the gold standard for hot flashes, and we know that it works topically or systemically for maintaining normal vaginal vulvar function as well. So these are summary slides you can read through, and we can talk more about it at the end. The next part, I just want to show you real quickly, there is an app put out by the North American Menopause Society. If you're not familiar with that group and your medicine or your family practice, you take care of a lot of menopausal women, I would refer you to that site. It's www.menopause.org. It's a non-biased scientific group of individuals who review all the literature and put out white paper type statements periodically addressing what's consensus and what's questionable regarding all the issues regarding menopause. And there's an app that you can get for free that you can download that's here, and it is you can say if you're a patient or the provider, and it guides the patient so she knows what her risks are. She can do this at home or wherever. You can do it in the office. You can actually, from your phone, you can go through it with her in the office in less than 2 minutes, and you can put her email in and send her the report directly to her email. And these are summary slides. And then osteoporosis, I just kind of put in who should be screened, what the risk factors are. Again, go into the app, using the FRAX algorithm, which is what we use for women who are postmenopausal but not age 65 yet, and or we think they have risk factors. We can do the FRAX test on them, which counts for these risk factors that we already all know about. Using the FRAX app, and this is, I believe, free, but I can't remember for sure, but it's a good app. Again, if you're doing this stuff in your office, it screens it very quickly and helps guide you to determine what their risk is for a major osteoporotic fracture or hip fracture in the next 10 years. And then you can kind of guide them along that way, talk about calcium, vitamin D, how often to repeat DEXA scanning in a woman over 65 is covered in a slide here as well. We can come back and talk about that if you want. And then finally, the clinician's guide to osteoporosis and bone care, put up by the National Osteoporosis Foundation, is free. You can download it or you can order it. If you want the booklet copy, you can order it for free through the mail. It's a really good resource, I think, and easy to use. And this is our goal, keeping our aging population physically active. I'm not sure I could do that, what she's doing there at age 12, but some people can. And then there's probably a few U of M fans in this room, and maybe some Spartan fans. So just in case, I'll leave you with this thought. Now, the fracture that this young man sustained had nothing to do with osteoporosis. It had to do with excessive celebration after we marched down the field and scored a touchdown with no time on the clock.